This session will be very interesting for spine surgeons, neurosurgeons. In this session, we will enter into the core spine surgery or neurosurgery. So many of my juniors, you keep asking me what are the important tricks, techniques for operating intramedullary tumors like ependymoma. We'll just focus on ependymoma because ependymoma is well marginated. So in ependymoma, the outcomes may be good. So I've decided that in this session, I will give a brief overview of all the steps of ependymoma surgery. In my next sessions, in each session, we'll concentrate on one particular step so that by the end of this series, maybe 8, 9, or 10 videos, you will understand each step of surgery with crystal clear clarity so that you can give the best outcomes for our patients. So, how to surgically remove spinal cord ependymomas? All the important tricks. So, this is an overview of all the steps. And then in the next sessions, I will concentrate on each particular step in each session. Let us not hurry up. Let us be slow, keep our pace, keep learning each step in each session. So, let us take example of this case. This is a very small tumor, but with extensive serines. I hope you can see the serines. This is a tumor. This is the axial cut. So let us plan. So what is the extent of bony exposure? And because the posterior approach, that is surgery from the back, is very common, we will speak about the posterior approach. So this tumor, if I have to remove, when I am coming from the back, when I'm coming from the back, okay, I need sufficient exposure. So if I have to reach this, I will have to expose the tumor completely. So where is this tumor located? Let's see. This is C2, C3, C4, C5, C6, C7, D1, D2, and D3. So this is at the level of D2 and D3 vertebra. So I need adequate exposure. So my plan is to remove D2 and D3 lamina. That is this portion of the lamina I will remove. So this D2 and D3, this will be the extent of my bony removal or laminectomy. So the vertical extent of laminectomy I've decided from here to here. This preoperatively, I personally prefer to use a marker MRI where I use vitamin E capsules while taking the MRI. Even if it entitles me for an extra MRI, I go for it. Because during surgery, I don't want to keep searching for the tumor, do unnecessary bone removal. I need to be more accurate and precise. So I always take a marker MRI before going for surgery. So taking a marker MRI, I plan this way. How to take in marker MRI, I will be detailing in my next videos. Then coming to the axial cut. You can see the tumor as the spinal cord is negligible. I will draw the tumor. So this white structure is the tumor. Okay. And where is the spinal cord? See, the spinal cord is not very much. It is as much as a thin strip. I think it should be less than 5 mm. The structure between both the red lines is the spinal cord tumor. That is a spinal cord. You can see here. This is the normal width of the spinal cord. Okay. This is a spinal cord with syrinx. Syrinx is accumulation of water within the spinal cord. And at the level of the tumor, you see, only this thin narrow line which I'm drawing is the spinal cord. You can see above and down. So the spinal cord has been excessively thinned out. That is why this patient has weakness. So because his spinal cord is very thinned out and it's reaching the surface, I'm going to enter from the midline from the posterior approach, that is from the back. So my idea is to remove this part of the bone, which is the lamina, and then enter the tumor strictly in the midline. So this is the marking. I have ensured level of tumor with a marker MRI before the surgery. Even if I have to do an extra MRI for marking, I do it, because this makes the surgery more precise, more safer, lesser incision, lesser post-operative pain, and it decreases the duration of your surgery. I don't want to waste my time during surgery trying to localize the tumor in the dorsal spine, where it's very difficult to localize with an X-ray because your shoulders keep coming in between and it's not very clearly seen on an intraoperative X-ray or an MRI. I meant to say intraoperative C-arm. The head is well supported. Here they have used a 3-pin headrest. You can also use a head frame headrest. See, the lamina has been removed. This is the dura which has been reflected. You can see this dura, the thin covering over the spinal cord. Once this is the opposite side that has been cut and reflected apart. Once you reflect the dura matter, the thin transparent arachnoid matter comes in picture. You can say this thin transparent arachnoid matter, and within the through the arachnoid matter you can see the spinal cord in its vessels. So between the spinal cord and the arachnoid matter is the water of the spinal cord, which is the cerebrospinal fluid. Then I incise the arachnoid matter. I need to do it carefully, under magnification, under a very good surgical microscope, under brilliant illumination, using microsurgical techniques. I'm using a micro hook. So gently I will incise it, and I'm using the micro hook. I open it in the midline in this direction. Because it's under the microscope, I can clearly visualize this layer. I can clearly visualize the underlying spinal cord. And when I'm tearing it apart, I will ensure that I am not injuring the spinal cord. At the same time, I will ensure that there is no blood leaking into my surgical site. I will use patties and lints over. You can see this patty and lint, white structure. These are put to ward off the blood seeping in from the muscles into the surgical field. This is once I open the dura mater. Now I can see the tumor is bulging. So this is one more sign that I'm at the correct level. I've decided to enter the spinal cord in the midline because it's thinned out. Now my challenge is how to identify the midline. Yeah. See, now these are the spinal nerves. Can you see on one side? This is the cranial, this is the caudal. The patient is sleeping this side. Okay. This is cranial. This is caudal. That is, this is leg end of the patient. This is the head end of the patient. This is left side of the patient. This is the right side of the patient. Now, to identify the midline, we know that the nerve roots exit from either side, on the left and the right. So this is the nerve roots on the left side, the root entry zone of the left nerve roots. And now you can see the nerve roots on the right side. This is the root entry zone of the right side nerve roots. So exactly in between, we have the midline. Understood? This is the midline. The second way to identify the midline is you will have a number of small capillary blood vessels coming out from the midline. So I have identified the midline carefully. I have identified the swelling in the spinal cord, which localizes the tumor. Once I've identified the midline, I have partially coagulated small capillary blood vessels. But if there is a very big blood vessel, do not coagulate it. Use microsurgical techniques, try to deflect it. But here there were small capillary vessels which indeed direct me to the midline. Have coagulated it to make the midline avascular. Can you see this avascular midline, which I made it with coagulation? Then I incise it. Incision, be careful, be very precise, very slow. Once we incise it, the ependymoma comes in picture. The ependymoma is easy to identify from the normal spinal cord. If I was operating a astrocytoma, identifying the tumor will be difficult because astrocytoma has a color and texture similar to normal spinal cord. So those slight difference in texture, color, it requires the experience of a neurosurgeon. But for a neurosurgeon, the ependymoma majority of times is easy to identify, unlike an astrocytoma. So this grayish structure, which is vascular, which has a clear margin from the spinal cord in grade 1 and grade 2 tumors. But in grade 3 and grade 4, even there may be color difference, but you may not find a cleavage plane because the tumor infiltrates into the spinal cord in grade 3 and grade 4. Now, I cannot retract this spinal cord. I can't pull it like I do it in this abdominal surgeries. I cannot do it the way I do in other surgeries. So, how do I retract this normal spinal cord? See, have taken a stitch. Can you identify this stitch? Have taken a stitch through the thin layer of pia mater which is adherent to the spinal cord. The shiny structure which is on the entire surface of the spinal cord is the pia mater. Through that one, using a very thin stitch, somewhere like of a size of 605040, I take a stitch through the pia mater and then I stitch it to the surrounding dura mater. So this applies gentle traction on the normal spinal cord, which doesn't injure the spinal cord, but at the same time, it provides adequate resection for us to proceed to the next step of tumor removal, which is the most important one. So these are the pial hitch sutures. Once I've gone through the pial hitch sutures, I gently, using microsurgical instruments, separate the tumor from the left and right parts of the spinal cord. You can see. While doing this one, I use my bipolar. This is my bipolar to gently coagulate the surface of the tumor so that the tumor will get shrunken. The tumor will become less vascular. I alternate the shrinking of the tumor with dissection to develop a plane. That is, I develop the plane, then shrink the tumor, make it avascular. Again, I develop the plane, again, I shrink and make it avascular. Again, shrink, again, develop a plane. By repeating this process, see, here I'm separating the plane. In the previous one, I was shrinking it, separating, shrinking it. In the meantime, I'm developing the plane between the tumor and the spinal cord. I'm shrinking and separating it. So gradually I develop a very clear plane. You can see this plane. I'm separating a tumor from the spinal cord. Here also I'm developing a spinal cord. Gradually I develop the plane and the cranial part, cranial and caudal part. That is, I identify and separate the poles of the tumor. That is why in our first planning we have made an adequate laminectomy so that I will be able to see the cranial pole and the caudal pole of the tumor. Once the cranial pole and the caudal pole is separated, you hold the pole of the tumor, apply gentle traction, and then visualize the anterior surface or the ventral surface of the spinal cord. Once I identify the ventral surface of the spinal cord, that is surface of spinal cord in the front side of the tumor, I continue my microsurgical dissection of shrinking and separation, alternative, so that I completely, circumferentially, from all the directions, from the cranial, from the left, from the right, from the caudal, from all the directions, I gently separate the tumor from the spinal cord. This is the end. I've completed all the separation, remove the spinal cord tumor. This is neat spinal cord which has not been damaged. There is no bleeding. If there is bleeding, I use gentle coagulation, or before using that one, I use Abgel, Surgicel, and all the neurosurgical techniques to achieve a good hemostasis. Once hemostasis is secured, a watertight duroplastry is done. and routine closure is done in layers. This is a post-operative scan of the same patient. There is no tumor. The rings are resolved. You can see the spinal cord, and the patient has recovered without any neurological deficits. Thank you. So, I hope I have been very clear regarding each step, but this is not all. Each step has a number of precautions which you have to take. So, in next my series, we will come from each step. How to plan the laminectomy, how to open the dura mater, how to open the arachnoid mater, how do you take the pile sutures, how do you do the microsurgical dissection, how do you ensure the hemostasis, how do you close the dura mater, how do you close the skin, what is the post-operative care, when do you monitor the patient. All these things I'll be discussing in detail in each session. So keep subscribed to my channel. Do share with your fellow colleagues. And if your any patient asks you for this procedure, you can share my video with them. Thank you.